This lesson, I will discuss about thyroid physiology, function, regulation, and the thyroid function test or thyroid studies. To start from thyroid physiology, the main function of thyroid gland is to synthesize T4 and T3, and the only known physiological role of iodine is in the synthesis of these hormones. Whatever the chemical form ingested, iodine eventually reaches the thyroid gland as it is ionized form or iodide. Thyroid tissue has an avidity for iodide and is able to trap, transport, and concentrate it in the follicular lumen for synthesis of thyroid hormone. To form thyroid hormone, trapped inorganic iodide must be organified into tyrosine residues of thyroglobulin in the follicular lumen. Iodination of about 14 of these tyrosines forms monoiodotyrosine or diiodotyrosine. Two molecules of diiodotyrosine then couple to form one molecule of 2,4 and one molecule of diiodotyrosine and one of monoiodotyrosine coupled to form T3. Once formed, hormones remain stored as a part of thyroglobulin in the colloid of the follicular lumen until ready to be secreted from the thyroid. In adults, thyroid secretes approximately 85 microgram of T4 and 6 to 7 microgram of T3 daily. Only 20% of circulating T3 is secreted by the thyroid, while the remainder is produced by deiodination of T4 in extrathyroidal tissue by iodotyrosine deiodinase type 1 and type 2 iodotyrosine deiodinase. In the pituitary and the brain, approximately 80% of required T3 is produced locally from T4 by type 2 deiodinase. Also, it is present in the blood only about 1/5 the concentration of T4. T3 is a physiologically active thyroid hormone. Because it binds the thyroid hormone receptor with 10 to 50-fold greater affinity than T4. So T3 is a physiologically active thyroid hormone. Let's see thyroid hormone function. Entry of T4 and T3 into cells is facilitated by specific thyroid hormone transporters. And once inside the cell, T4 is converted to T3 by type 1 or 2 deiodinase, as I have said. Intracellular T3 then enters the nucleus and binds to thyroid hormone receptor. Binding of T3 to the thyroid hormone receptor causes recruitment of coactive molecules, transcription of messenger RNA, and protein synthesis. Thyroid stimulating hormone synthesis and release are stimulated by thyrotropin releasing hormone, a tripeptide that is synthesized in the hypothalamus and secreted into the pituitary. In states of decreased thyroid hormone, thyroid stimulating hormone and thyrotropin releasing hormone are increased, while increased thyroid hormone inhibits thyroid stimulating hormone and thyrotropin releasing hormone production. Also, TSH levels can be measured in serum. Circulating levels of thyrotropin releasing hormone are very low outside the neonatal period. Further control of the level of circulating thyroid hormones occurs in the periphery. In many non-thyroidal illness, circulating T3 levels fall due to decreased extrathyroidal production of T3 by type 1 deiodinase and increased inactivation of T4 to reverse T3 by type 3 deiodinase. These changes may be induced by factors such as fasting, chronic malnutrition, acute illness, and certain drugs. So in this case, measuring free T4 alone might affect the real T4 level. Although levels of T3 might significantly decrease, levels of free T4 and TSH may remain normal in this case. The decreased levels of T3 might be physiologic adaptation, resulting in decreased rates of oxygen consumption, of substrate use, and of other catabolic. The third part is about thyroid function test. Methods are available to measure all the thyroid hormones in serum, T4, T3, free T4, and free T3. Direct free T4 assays are generally reliable in healthy patients. However, this assay might be unreliable during acute illness or with severe abnormalities of thyroid hormone binding. Therefore, in such situation, it might be preferable to measure total T4 and the index of thyroid binding globulin level. Many free T3 assays are poorly standardized and their clinical utility is limited. Age must be considered in interpreting all thyroid hormone results, particularly in the neonate. Serum thyroid stimulating hormone levels are the most sensitive test for primary thyroid dysfunction. Serum TSH levels are elevated in primary hypothyroidism and suppressed in primary hyperthyroidism. After the neonatal period, normal levels of TSH are less than 5 international units per liter. In central or secondary hypothyroidism, or if the problem is from hypothalamus, serum TSH is either low or inappropriately low or inappropriately in the normal range despite a low serum T4 or free T4 levels. Although it might be normal in concentration, TSH is less biologically active in patients with central hypothyroidism. Regarding neonatal period, at birth there is an acute release of thyroid stimulating hormone with peak serum concentration reaching 70 to 1000 30 minutes following delivery in full-term infantis. A rapid decline occurs over the next 24 hours and a more gradual decline over the next 5 days to less than 10, and the acute increase in TSH produces a dramatic increase in levels of T4 to approximately 60 and T3 of approximately to 300 nanogram per dl in about 4 hours. Serum free T4 levels are between 0.9 to 2.3 nanogram per dl in infancy and decline to 0.7 to 1.8 nanogram per dl in childhood. This T3 appears to be largely derived from increased peripheral conversion of T4 to T3. T4 levels gradually decrease during the next 2 weeks of life to 10 to 12 microgram per dl. T3 levels decline during the first week of life to below 200 nanogram per dl. In preterm infantis, changes in thyroid function after birth are qualitatively similar to but quantitatively smaller in full-term infantis. Serum T4 and T3 levels are decreased in proportion to gestational age and birth. Let's see serum thyroxine binding globulin. The thyroid hormones are transported in plasma bound primarily to thyroxine binding globulin, a glycoprotein synthesized in the liver. Estimation of thyroxine binding globulin is occasionally necessary because it is increased or decreased in a variety of clinical situations with effect on the level of total T4 and T3. Thyroxine binding globulin binds approximately 70% of T4 and 50% of T3. Thyroxine binding globulin levels increase in pregnancy, newborn period, hepatitis, administration of estrogen such as OCP, selective estrogen receptor modulators, and heroin or methadone abuse or use. And it decreases with androgens, anabolic steroids, glucocorticoids, nicotinic acids, and L-asparaginase use. These effects are the result of modulation of hepatic synthesis of thyroxine binding globulin. Thyroxine binding globulin levels might be markedly decreased owing to decreased production with hepatocellular disease or due to massive protein use in the gastrointestinal tract or in the urine. Some drugs, including Lasix, salicylates, non-steroidal anti-inflammatory drugs, and heparin, as well as free fatty acids, inhibit binding of T4 and T3 to thyroxine binding globulin or TBG. In addition, phenytoin, carbamazepine, phenobarb, and rifampicin can decrease T4 levels by stimulating hepatic cytochrome P450 mediated conjugation and excretion of T4. Thank you for watching.